Oh, okay. Because that way it actually has time to work.
Right. So it's the alveoli that we've all talked about with respiratory distress and complications of the newborn. So although they are present in infants as early as 32 weeks, they're really not uniformly present and functioning until 36 weeks. They are necessary for this exchange of oxygen and carbon dioxide, and if you don't have enough alveoli, then you're going to have a lot of lung issues. Okay, so here's the next one. So it's an artist's depiction. These aren't photographs of fetal lungs. But 8 weeks you have some buds, 16 weeks you're getting better, 24 to 35 weeks they're filling up, and then 36 weeks you can see the huge difference. Okay, so even up to 35 weeks, you know, you're still in that very creamy state. The two different types of surfactant is we use Infisurf. Most people on the East Coast do, and it is a surfacing agent. It's a liquid. I think everybody saw a vial of it. Draw it up in a syringe. They take the syringe and they shoot it down the endotracheal tube and bag it in, and it just disperses and gets absorbed into the lungs. And I've said it's really a miracle. You can have a baby that can't even ventilate. You give this, and all of a sudden they're wide open and pink.
And that's what they shake?
Yep.
Why they shake the baby?
Oh, for the oscillator?
Yeah. That's because you can't bag, like the one we saw, you can't bag.
Right. Yes. That 25 weeker, if you continue, well, I talked about it that day, if you have to use, no matter how soft of a ventilator you use, it's still causing trauma. And with each breath, it's causing trauma and the lungs are starting to swell. What happens is that process causes bronchopulmonary dysplasia where the lungs swell and then you're in a big problem. So the faster you can give the Infisurf, the better off you are.
And that baby got Infisurf.
Right in the delivery room. Yeah. So that high frequency ventilation, rather than giving the forceful breaths, just jiggles. And with the surfactant, it's just enough to keep the lungs and the sacs open. So, evaluation of respiratory distress syndrome. Vicki talked about retractions right here. This baby is not abdominally breathing. It's not going to be comfortable. Probably going to be nasal flaring. But right here is your indicator that something is not going right. This baby's using extra muscles to ventilate. And that is a warning sign. That baby would go from that, the previous picture, to that pretty quick. That baby probably needed surfactant and conventional ventilation.
I have a question. Why do they place the babies on their belly?
Because in premature infants, they don't have the reflux, and they ventilate better on their bellies. They just get a better oxygenation on their bellies. And they're on monitors, so we're always watching them. So the risk of SIDS is
So low, yeah.
Plus it gives them probably some resistance for trying to breathe on their own. Feels more maternal, more uterine. So it's the first question almost all parents ask. Why is my baby on their stomach? Because they're so used to being educated back to sleep now that they're afraid their babies are going to smother on their bellies. But we assure them they're always on monitors at all times.
Okay.
So, like I said, respiratory distress that continues to progress becomes bronchopulmonary dysplasia, and that is the swollen obstruction of the lungs due to it says prolonged oxygen therapy, but it's ventilation therapy. It's the vent that causes bronchopulmonary dysplasia. All right, behind these two here.
Is that just it's swelling?
Yeah. All right, so this is a parent-teaching sheet on RDS, but it nicely sums up respiratory distress syndrome in infants and in newborns. So it goes over, it shows you another picture there of a healthy lung. Now imagine that alveoli collapsing and being stuck together like it's got Elmer's glue in there. So as soon as you put some, Dawn dish detergent in there and break up that sticky, they pop back open. And that's exactly what happens. It's also invented in Buffalo.
Nice.
Yeah.
Hey.
So respiratory distress syndrome, before we even get to BPD, but respiratory distress syndrome. So What do you think the first thing you're gonna see in a baby that's going into respiratory distress syndrome?
Nasal flaring.
Nasal flaring. What will you hear?
Grunting.
Grunting. And grunting usually comes before the nasal flaring. They are trying to, they're trying to, that is audible, you can hear it, and then it progresses. I wish I could have videotaped it this weekend, because it was textbook, grunting. And from the normal newborn nursery, the baby came, and the nurse said, this baby's grunting. Doctor said, keep him down there and see what he does, see if he clears it out. He did not clear it out, and he ended up getting 2 doses of Invisurf, because he just didn't get better. So,
Oh. And that baby was 36 weeks?
he was 37.
37 weeks.
37 week C-section, yep.
That's almost a full term.
Right, and that's, the father was shocked.
Did he bail her down to 37?
Yes. Yep. So, try not to share too much, but they also had another child that had a tetralogy of Fallot, spent 3 months in the hospital, all kinds of complications, is 6 years old. And here they expected, a term. He thought the baby, he said, I was told at 37 weeks my baby was full term. And of course we're like, well, some babies don't develop surfactant until 36 weeks. And he's like, no, we're sure he's 37, but regardless, he had it, and that's the picture. And this is what he got handed to go down and explain it to his family.
Why would they do a C-section at 37?
She was, he said that she was starting to have some placenta complications, so.
Huh.
But one more week probably would have made a lot of difference for him.
Yeah. In a couple of days, probably.
Okay, so with respiratory distress, you're gonna hear grunting. Apnea is another complication of the high-risk newborn. If you have a baby that is apneic, not taking a breath for 20 seconds, having any sort of color change, they are deemed apneic. When a baby is apneic, they can become hypoxic, and it's a sign that something is going on. In a full-term normal newborn, they should not have apnea. They can have periodic breathing, which is why you count the respirations for 1 full minute. But if they have stopped breathing for 20 seconds or more, you start noticing that they're having these pauses that are longer than they should be, then you need to look for other things. And some of those things are anemia. The baby could have reflux, heart or lung problems, infection. So if this baby is apneic, and not looking quite right, what would you expect his temperature to do? Why would the nurse go over there and automatically start taking a temperature and doing vital signs? What is a baby that's apneic, you're concerned about sepsis,
Cold and
cold, yep. And I saw that question repeating itself on some of the NICLEX tests that I saw. So 1/3 of infants less than 30 weeks will have apnea of prematurity. In the premature babies, we expect it, it's common, and there's a few things that we do about it. So in a preterm infant that has apnea, we have some treatments. Theophylline, bronchodilator, keeps them stimulated and awake. Caffeine is what they usually get first. And caffeine does to them exactly what it does to us. It keeps them alert. And parents get a kick out of that for some reason. They're like, your baby's getting caffeine, just like we would get caffeine, and it works.
My dog OD'd on caffeine this weekend. She ate a bunch of chocolate-covered espresso beans.
Oh no.
She had to go to a puppy ICU.
Was it dark chocolate? Because I heard dark chocolate.
Yeah, it was like,
dark
the
chocolate's
apex,
bad.
the vet said it was like the apex of dog poison.
Oh
Oh.
Yeah,
she's
chocolate's
so
really bad for dogs.
Yeah. Is she out?
Yeah, she's okay now, but like the chocolate and the caffeine both metabolize into the same thing, and I guess the half-life of caffeine is 72 hours, so they had to watch her.
Oh my gosh.
Yeah, my dad was so mad.
I bet it is.
Like snot dog.
Is that where you want to work? Chocolate-covered coffee.
Oh. Chocolate-covered coffee base. Oh my gosh.
Delicious.
We took our dog to the vet for he ate like a half a ham. And and as soon as we walked through the door, before I even did anything, she's like, here's what we're estimating it's gonna cost minimally. I'm like, oh.
I know, they chose like sheet of paper.
You have to sign it right inside the door.
That was a hungry puppy.
Half a ham.
It's a dog. A little one too. So for apnea, when a baby's having an apneic spell in the NICU, they're on a monitor, the alarm goes off, we just stimulate, you pat their butt, you wake them up a little bit, and you document your nursing note. The time of the apnea, how long it lasted, and what you did to wake the baby up. If the baby continues to have apnea more than 7 in 24 hours, then they get a sepsis workup.
If they have apnea for how long? Sorry.
More than 7,
hours.
if it's in a NICU, if they start having apnea spells, again, one of those signs that something's going on. A baby that's apneic in the newborn nursery is going to the NICU.
But you said 7 in an hour?
And
7.
it's 24 hours.
Oh,
7 apneic spells. We keep a log, and as soon as they start hitting 5, you're letting the doctor know this baby's having spells. And by 6, you're concerned 7, they're getting a CBC and a workup.
Okay, sorry.
That's okay. So, after you're in the delivery room, you've established that you can ventilate them, they're over 23 weeks, and you have some respiration. The next thing, obviously, in your nursing scope of practice here is making sure that they can have circulation. So oxygenation and then circulation. So, Vicki touched upon the patent ductus arteriosus, and in a premature infant, if that stays open, well, if it stays open in anybody, but in an infant, who remembers what's the mechanism of a PDA? What does it do?
It brings the blood, it shunts it into the artery, but then that pumps it out, doesn't it?
Yep, it keeps it open so that in the uterus, the baby doesn't need blood and, blood to oxygenate in the lungs, it just needs fluid. So that duct stays open so that the majority of the blood bypasses the lungs.
Right.
Yes. So in a normal adapting full-term infant,
They wouldn't get.
those first couple breaths, transition's going normally, it closes, the blood goes into the lungs, and the baby's nice and pink and glowing. In the event that PDA does not close, you've
Blood
got
doesn't get-
blood mixing around, it's not effectively going into the lungs,
That
you have an audible murmur, and there's a problem.
Okay.
In the normal newborn, you will hear that, you can hear it for 12 to 24 to 48 hours, and it is not concerned if the baby's staying oxygenated, doing well, no big deal. And where it causes serious concerns is when it stays open for a long period in the preemie who didn't have that normal transition to the extra uterine world, and in that case, there's medicine that treats the PDA, and it's called indomethacin. And if you want to write that, there's a little note section on the back. So indomethacin is a dose. It's given in 3 doses in the NICU. If the PDA is determined by echocardiogram to be open. And here's
What is that called? Sorry.
It's called indomethacin.
That's to help close it?
It will close the PDA. Yep.
Thank you.
Okay.
Is it like a steroid too? Or like what is it?
It is, the exact mechanism of indomethacin is, I would believe, in the vasoconstriction field, because
Okay.
it's also given prophylactically to stop intraventricular hemorrhage in a very premature baby. Okay? So there's a nice picture there, and it explains how, remember, arteries in us carry oxygenated blood away, but in utero, it's the exact opposite. Okay, PDAs are more common in premature babies, and almost half of babies weighing less than 3 pounds, 13 ounces will have this problem. The extreme form of the high-risk baby is called a PDA ligation, where the surgeon will go in and actually stitch that valve shut. And if the baby isn't growing, is having spells, apnea spells, can't keep them oxygenated, and they've tried indomethacin, sometimes they'll try a second course of indomethacin. If that doesn't work, the baby gets a PDA ligation and they will close it. And they do that right in our hospital, right in our unit. So the baby can oxygenate, circulation. Number 3, body temperature. So thermal regulation is very important. There's a radiant warmer, everybody saw one, you have to maintain that temperature. Aha, back to this. Convection, radiation, evaporation, and conduction. In that delivery room, the first thing you're gonna, first one of heat loss mechanisms that we're gonna take care of is that evaporation. That is skin to air, wet linen. As soon as you get that baby and you're drying the baby off, whether it's over on the mom's abdomen or if it's on the radiant warmer, as soon as that blanket is wet, you discard it, you get a dry one, a warm one, and keep that baby warm. Okay, can someone give me an example of a convection? Where would a baby lose heat from convection? I know it says transfer from heat to a solid object.
The cold
Like a
table.
scale. Cold.
Yep. What about radiation?
That was the window one.
Yep, we can scissor, yep. And then conduction. And these are on the NICLEX as well.
Yeah,
This is
they're
one of the things in the NICLEX that you do have to have a good understanding of. Okay, so conduction is a heat loss as a result of surfaces of different temperatures coming in contact.
So that would
with
be
each
the
other.
scale.
That's the cold
Yeah,
scale.
conduction
It can-
is the scale.
Yeah, conduction is the scale, evacuation is the wet linens, radiation, when heat is transferred from two objects not in contact. So the baby to the wall or the window. We battle this all the time at the hospital. You get, the baby too close to the window and all of a sudden they're getting cold. It's the day of discharge. First thing we do is move them to a different location, make sure there's not a draft coming through, make sure they're not losing heat somewhere. Convection is heat from a solid object to the air,
So it's just
so a draft.
flowing up.
So the baby is just loosely wrapped in a little t-shirt, getting ready to go home. And there's the vent, it's circulating the air, so right in that vent. So it's from the solid object to the air, so it's right from the baby out to the air.
Yeah.
They can sit, now we've covered thermal regulation, adequate nutrition. The baby has to be able to eat. So you have to determine the nutritional needs, from extreme premature infant that's gonna be maintained with hyperal to the baby in the normal newborn nursery that needs to be able to breast or bottle feed. In the preterm infant, they go from gavage feedings to nipple to breast. But you can imagine that the complications, even in the newborn nursery, new moms trying to breastfeed, moms that are post C-section. So nutrition and feeding is an important thing to assess, and it can definitely place a baby in a high-risk category if you're having that weight loss, and babies not effectively having wet and poopy diapers. Fluids and hydration. IV fluids for babies in the NICU. You have to maintain their IV sites, from a peripheral IV to a PICC line, to umbilical lines and arterial lines. All care of the high-risk neonate if it needs to be. You're assessing IV sites just like you did on 2 North and 2 South or wherever else, assessing, for any wetness, redness, signs and symptoms of infection. Intraventricular hemorrhage. So, intraventricular hemorrhage in infants is less than 32 weeks, most often. It can result in the central nervous system and motor problems such as CP. Approximately 50% of IVH occur on the second, first postnatal day, 25 on the second, and 15 on the third, and less than 10% on the fourth. So you can see why that head ultrasound is done on the third day of life. So if you can make it past the third day of life without an intraventricular hemorrhage, you're doing pretty good. Intraventricular hemorrhages and they can be caused by prematurity, birth trauma, hypoxic insult, increased intracranial pressure, or hypertension. So
Is
this
that
is all,
hypertension in the mom or in the baby?
it can be in the baby. And premature babies can often get, say that 25 weeker all of a sudden had high blood pressure, it would be treated immediately.